All right, when we take a look at the ankle foot, we go to ankle foot. I thought this is a great place to talk about sprain strain, because we talk about this ankle sprain all the time in the anterior talofibular ligament, that inversion plantar flexion sprain, and we're going to adjust that all day long if it's just a grade 1, but if it's a grade 2, we might brace and support it because it's a little unstable. Grade 3, it has ruptured, right? So we're going to brace that and send it off to the ER so somebody can take care of that right away. Okay, the next two are kind of related to each other. There is shin splints and there's compartment syndrome. And as Dr. Laura brings that up, I want you to realize that shin splints is basically just a minor compartment syndrome, but no one calls it that. So realize that name will never be on your test, but that's really what it is. That's why shin splints can happen in the back of the leg or the calf, and nobody calls them calf splints. Okay, so when you go out and you run a lot or you do a lot of activity or somebody kicks you pretty hard in your lower leg, you have 4 compartments: anteromedial, anterolateral, posteromedial, and posterolateral. And if one of those starts to get full of fluid and gets a really tight fascia, okay, fascial swelling, you can trap the nerve and the blood flow. That's when it becomes compartment syndrome. If it's just a little mild swelling, kind of irritates and hurts every step you take, but you don't have any numbness in your foot or color changes in your foot, in other words, you haven't trapped the nerve and vessel, then probably you just have shin splints. Stretch it out, walk it off, work it, better warm-ups, moist hot packs, probably take care of it. But once it's allowed to swell to the point of neurovascular entrapment, it's limb-threatening. And that's why it becomes then not a life emergency, but a limb emergency. Okay, so this is absolutely, get to the hospital, let them decide if they need to kind of splay it open, and it can happen to your upper extremity as well. So forearms and legs are the places, the lower legs is where this happens. But I've only seen it, on chiropractic exams, I've only seen them talk about the lower extremities, so that's why I kept it here. All right, tarsal tunnel. Now instead of neurovascular, it's peripheral nerve entrapment only. So not the peripheral nerve, okay? That would be the neural part of this. But this is only the peripheral nerve itself being trapped. So tarsal tunnel is going to burn. See, Morton's neuroma is going to burn. So these two burn. But this one's a peripheral nerve that's trapped, that we truly call a peripheral nerve entrapment. This is a tumor. Okay, but we can adjust both of these. They get pretty good results with tarsal tunnel. We get so-so results with Morton's neuroma. But the problem with Morton's neuroma is when they do the surgery, it just grows right back. I mean, probably a little bit sarcastic, but it practically is starting to grow back before they can close them up. You know what I mean? So it really isn't worth getting the surgery done. So a lot of times if you do some ultrasound and adjusting, you can kind of keep the pain sort of on the lower end of the spectrum. So we can adjust tarsal tunnel, we can adjust Morton's neuroma. Obviously, if somebody has a March fracture, we're going to reduce the stress. Now, March fractures usually are self-limiting. They usually heal themselves. It's good to take a picture of it and see if it's lined up. And as long as it is, usually just a little bit more rest, and you can take some pressure off that. But you'll want to evaluate the surface, the activity, the shoes. You need to do a full evaluation of just what's going on activity-wise in their lives. Metatarsalgia usually is related to just a dropped metatarsal head, so usually adjustment is a real good way to remedy that. All right, a little left in the foot. Let's take a look at what we've got. Plantar fasciitis. Now, plantar fasciitis really amounts to, let me put this down, is that when your toes hit the floor, okay, your heel should hit almost at the same time. Remember, because we're coming down like this? So actually your heel, then your toes hit, but when your full weight gets on that, you kind of squoosh the foot like that, okay? Gadushka is what I usually say. But if you're going bam, 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 so in other words, you're bam, 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 you're rocking on it like this, then you are going to irritate that heel spur, and that's called a rigid foot. And that's how plantar fasciitis gets started. This little attachment, all this tissue crust here is called the aponeurosis. So plantar fasciitis is an aponeurosis problem, and what happens is it leads into a heel spur. Bam, 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 bam. So that's why we want to get that foot adjusted and moving and mobile so that things are rocking and it's springing better, and those are the kinds of things that we want to have happen. All right, now we talked about that there's some antibiotics that can rupture ligaments, right? Just, spontaneous ruptures. But, we can certainly happen in volleyball or a football game or whatever. So if somebody has a ruptured Achilles tendon, then of course we're not going to adjust them. We need to stabilize that and get it off to the hospital. Morton's syndrome I just threw in there because sometimes it's a distractor. I don't know so much it'd make a good case, but it's when your big toe, which should be taller, is shorter than your second toe. So when that happens, your push-off changes just a little bit. Okay, so that can cause a little less stable foot, and so you get a few extra adjustments for taking care of that foot. Next, we go to the spine. Now, the good news about the spine is there's not two. So remember, in everything we've been talking about, there's a well side and a sick side, unless both sides are involved. So when we get to the cervical spine, just a quick check. If somebody came in and you thought it was a disc, a cervical disc lesion, do you think you'd take care of most of those cases? And I hope your answer is yes. I'd want to adjust that and apply all the rules that I know about, imbibition and flexion distraction, and talk about chondroitin sulfates, and so off you go. And there's a lot of information up there for you to talk about. Now, if somebody came in and you thought it was a cervical tumor, no, you're not going to adjust that. How about IVF encroachment? Sure, yeah, we're good at that. How about torticollis? Yeah, line them up, right? How about strain sprain? Now, doesn't that depend on whether it's grade 1, grade 2, or grade 3? Remember, if the spine's unstable, we're not going to touch it. So exactly right. It's going to vary, and we have to do evaluation. Now, I want to show them the alley out here, Dr. Laura, so bring this over this way a little bit. Okay, now, you all can read the rest of your page here, but what I want you to see is from F all the way down to I, Barry, Lou, Wallenberg, benign positional labyrinthitis, these are all dizzies. So these patients are all complaining of dizziness and vertigo. Don't worry about the difference between those two words for right now. I know one's the room whirling and one's the patient whirling around the room, whatever. Okay, but the point is these people are imbalanced, they're dizzy, and we've got to decide if we're going to take care of them or not. So what I wanted you to just quickly understand is Barry Lou is yours, Wallenberg isn't, benign positional is yours, and labyrinthitis is yours as long as it's not related to infection. If it's just a little swollen labyrinth, you can take care of it. So Barry Lou, we think that the vertebral artery is swollen and it kind of makes them dizzy when they rotate their head. Wallenberg syndrome means that after a car accident, they kind of walk and just all of a sudden have drop attacks and fall down, half their body goes numb. Positional vertigo is based on the fact that there's a little piece of debris kind of loose in your semicircular canals, and so every once in a while when you turn your head this way or turn your head that way or look up or look down, it's always a different position, but you get a little dizzy for a few seconds. Okay, and finally, labyrinthitis is just momentary dizziness or motion sickness when you move a lot and you tend to, maybe even throw up. So what I want you to understand on all of these is that you need to know what brought it on and then the right question to ask. So I want you to understand all of these can be related to trauma. So if somebody is dizzy, one of the first things I want you to ask is, have you had any trauma? Because the answer is yes, 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 yes to all of these potentially. There is one very common on your test that is not related to trauma. So I want you to right now, I put it in a different place in your book. It's going to be in the neuro section. We're going to do, it's upcoming. Okay, but I want you to realize Meniere's is not due to trauma. Okay, trauma, either infection or trauma labyrinthitis. Meniere's, no trauma. So if they say, now I want you to follow this, if they say, hey, I'm dizzy, you say trauma, they say no, you think Meniere's. And then you ask if they have ringing in their ears. If they have ringing or transient deafness, it's Meniere's. Okay, now, the bottom of this page we got TOS, and hopefully I know you know it's a peripheral nerve entrapment. It can also be called a neurovascular entrapment, if you'll remember back. But what we want to do is, of course it's our case, but would you trigger point the scalenes? Wouldn't that be a silly thing to do if it was a pec minor syndrome? You see, and that's why we've got to decide, is it the scalenes that are the problem, is it the first rib in the clavicle, or is it the pec minor? So you have some good orthopedic testing that you can do to find the right target tissues to take care of this neuropathy. Now, when it comes to whiplash, I would say our schools kind of introduce the subject to most of the student population, but we don't get very far into it. We don't talk about high impact, low impact speeds, flexion with rotation, flexion with lateral bending, flexion hip from behind, and and rotational, or so it gets very complicated very quickly. To be a personal injury expert requires some real advanced soft tissue study, and Dr. Croft is probably one of the best instructors we have in that. If ever you can take a Croft seminar, or he's in your town or speaking at your convention, by all means attend that, because you'll really want his information. Now, when we look at it, let's just stick to the real basics. If we are talking about, and I'll face this way, so I'm facing the same way as this picture. If I get hit from the front, okay, or I run into something, okay, that means that the car is going to stop, but I keep moving. So that is a front-end collision, but that's what we call deacceleration. Okay, is that we're trying to deaccelerate, we're just not doing it fast enough. And so that is going to have what we call a hyperflexion and then a hyperextension whip. So that's a hyperflexion, hyperextension. If we are hit from behind, somebody, you're sitting at a light and somebody gets you in the back because they're texting. Okay, so boom, you do this, so you have hyperextension, then hyperflexion. That first impact, okay, is the worst, and then it kind of okay. So what you look at is that the symptoms for both of these are similar. Got a headache, dizzy, nauseous, not feeling good, muscle splinting, that kind of thing. So symptoms don't give it away, but if the patient can tell you what happened, I was hit from behind, or you get the report from the officer of the accident report, if you look at neutral and you think hyperflexion, then you're going to see avulsion fractures of the spinuses, but compression fractures of the vertebra. If you look over here, here's neutral, here's hyperextension, you're going to probably strain the SCM, which is this, maybe rupture the stylohyoid, which calcifies a lot. You might rupture the ALL ligament. You'll probably have comminuted, just multiple pieces of the spinous processes, maybe a avulsion fracture of the vertebra. So if you understand the mechanism of injury, you can predict what the injuries are. Now, sometimes the patient can't tell you the injury, which means concussion should be on your list of problems. If there is a memory loss, then concussion becomes a possibility, and that usually is taken care of by other doctors, and then we'll co-care a little bit later in the case. Now, one thing I did here is I just kind of threw this in, number 2, to remind you there are vascular things like the vertebral artery we're worried about. We've got muscle splinting that is going to be a part of this case, and both peripheral and central nervous system. So your evaluation, go ahead and bring this up, Dr. Laura, has to be very thorough. So when it comes to this, we all should know that if somebody's brought right in, like they just got in an accident in your parking lot, that your first job is to say, hey, are you okay? You're monitoring their vitals. What happened? Can you explain it to me? Do you remember? So you're practically monitoring the vitals while you're getting a history, looking in their eyes, seeing if they're coherent. So it's almost a combo of you're assessing them for the emergency while you're doing this brief history, finding out if indeed they've had head trauma and you're real concerned about any other pathologies. Now, after you've done that, if you feel pretty comfortable that this looks like it could be my case, then you go right into your Davis series before you do a lot of physical exam. And the first part of the Davis series is that you don't move the patient. And some people don't even want to move the patient's mouth and open the mouth. So instead of they'll go up and aim up to get it, to get the A to P open mouth, or in other words, the C1 and C2 vertebra. So we call that the Fuchs view. Now I have put the names of most of the views in the series and their purpose in the back of your X-ray books. You have a nice synopsis of all that. So in case you think, oh, I'm not too good at that, well then we'll take care of that. Don't worry about that. But these are all neutral. If you look these over and say, hey, things look pretty good, then you can start moving the patient around and doing obliques and doing lateral bending and flexion extension. And, this is just kind of the basics. There's probably a good 20, 30 x-rays that could be taken as part of an extended Davis series. Now, your neuro exam should be complete because central and peripheral nervous system involved. Orthos, one for target tissue, in other words, one for compression, one for traction, one for space occupying, etc., etc. Labs that you think are appropriate, and then, of course, treatment. If you've decided there's no real, fractures or anything, then realize that what we want to do is monitor the neurological compression signs and make sure nothing gets out of control there. Reevaluate within a few weeks and make sure what you're doing has some improvement on the patient, and then I think we're fine. Now down here at the bottom, there's just a little space left on the page, and I thought, well, what else could happen? And I wanted you to get the idea anything. So TMJs, migraines, Barry-Lou, lots of complications with this case. But I thought this gave me a good opportunity to talk to you about double crush. Because a lot of us have some misconceptions, or we just have one definition of double crush, and if it's not broad enough, you'll miss some of the things that double crush can be. See, double crush, probably about 2 decades ago, was introduced to most physicians as a whiplash injury followed by, oh, carpal tunnel in both hands the next day. So it made no sense that both hands would get it. Maybe the patient wasn't even holding the steering wheel. It was a mild fender bender. So what we understand is axoplasmic flow is probably subclinically already compromised. After this central nervous system barrage, it can't get out to the periphery, and you end up with this problem. Now, you can hurt your shoulder and end up with it. You can hurt your shoulder and get tunnel guyon. So instead of saying central nervous system to peripheral, it's better just to say a proximal to a distal. So if you'll say that, proximal lesion to a distal lesion, now let's put in the right words. Proximal neurological lesion leading to a peripheral neurological lesion is what double crush is. And you can take care of it.